Well, good afternoon, everybody. We're going to go ahead and get started so we're on time. My name is Mazen Abu-Fadel from the Oklahoma Heart Hospital in Oklahoma City. I'm going to ask the panelists to introduce themselves. You can share a microphone. We'll start from you, please.
My name's Katherine Kunkel. I'm an interventional cardiologist at the Piedmont Heart Institute in Atlanta, Georgia.
I am Lou Kohl, also an interventional cardiologist at Hennepin Healthcare, HCMC in Minneapolis.
Hi, I'm Jacqueline Tammis-Holland. I'm an interventional cardiologist at the Cleveland Clinic in Cleveland.
Hey, Anand, Prasad, I'm one of your moderators from San Antonio.
I'm Kostas Charitakis, interventional cardiologist at UT in Houston, Texas.
Hello, I'm Kechi Ijoma, interventional cardiologist at The Ohio State University in Columbus, Ohio.
All right, so just housekeeping, we'll have the speakers come up in sort of, they say TED Talk style. We'll try to keep the speakers in this central area in front of the camera there. Okay, so let's start off. Case one is lost a stent. Dr. Velagapudi.
Yeah, hi everyone. My name is Poonam Velagapudi and I'm an intervention cardiologist in the New York, New Jersey area. So I'm going to talk about this little case, short case first, and then how to retrieve stents. So these are my disclosures. So this is a old lady, 88-year-old woman who presented to the clinic with CCS class 3 angina that was not controlled with anti-anginal meds. Usually at this, we try all our best to control symptoms with meds. She had a history of CAD and a PCI to her RCA a couple of years back, hypertension, hyperlipidemia, and normal labs. So this is the coronary angiogram. The RCA is diseased in the ostium as well as in the mid portion. You can see that the takeoff is actually downgoing and there's about 70% lesion there, and then the mid RCA has 60 to 70% diffuse stenosis. The left system had mid-LAD disease and an ostial diag lesion, so it didn't really look very significant. And so, even before the procedure, the discussion was if we do find something, then we were going to fix it because her symptoms weren't controlled with meds, despite trying a lot of meds, and she couldn't tolerate more than what she was taking, and all her blood pressure and other things were under control. So, started off expecting this to be a simple procedure. The guide wasn't sitting right to begin with. It couldn't, since the JR wouldn't engage well, went with an AL guide. And then the lesion, we pre-dilated with a non-NC balloon, sequentially with a 2 and 3 by 15. But IVUS wouldn't pass. I mean, I think it was because of the tortuosity. And usually tried both IVUS, the Boston as well as the Vulcan. Vulcan is a little bit more stiffer, but both IVUS wouldn't pass. And so, at this point, the question was, the dilation was pretty good. The 2O balloon and the 3O balloons dilated well. So wanted to put a guide liner and see if we can get a stent across and then pull it back and then deploy it. Put the guide liner in, and when the guide liner was, when tried to advance the guide liner, everything was pushed back, and then everything came out. And if you see clearly in that image, everything came back except the stent. It was sitting in the ostium. So I'll just go back one slide. In the right image, you can see the stent is pretty clearly visible. Now, so the stent was lost in the RCA ostium. We don't have a wire, and there's no balloon, obviously, and the guide is out, and nothing is in there, so the stent is just free hanging. And then there's significant ostial disease still, which we think we did dilate well. Couldn't see it with the IVUS, so we don't know what exactly the lesion looks like. And there's that tortuosity in the ostium where it was difficult to engage the guide and pass any gear. So at this point, tried to re-engage. I mean, we tried a couple of other guides, but went back to the AL guide because the others wouldn't even sit. And then, yeah, okay.
Okay, perfect. Maybe the panel can discuss a little bit, right? So before you tell us what you did, which is great, let's first have a little discussion.
Okay, let's open it up to the panel. Just initial thoughts. Have you ever used the three-dimensional right guide?
3D RC, yes.
Yeah, 7 French 3D right.
Yeah,
Sometimes
it
it's really
wouldn't
helpful.
sit.
Yeah.
You know, it's a guide, whether it sits immediately, otherwise it just doesn't work.
You
It
can't
doesn't
really
matter,
manipulate
yeah.
much, yeah.
Yeah, so I feel like pain, and once the guide is not sitting, the whole case is just going to be a slog the whole time. I will share, when I started at my position 3 years ago, I had never really used a wiggle wire. And there's a famous quote, one of my partners is laughing in the audience. I said, wiggle wires are for old people. And I have lived that down and regret those words very much, because I think in the case where I'm fighting a guide, getting a supportive wire that's really going to help hold things in can be something that really can help kind of avoid this situation. But I think, you know, recognizing where you're at a high-risk moment, which obviously you did, taking the time to swap the wire out can be helpful to try to keep your gear in when you're fighting your guide the whole time.
Yeah, the other thing that you can think of using is guideline extension just from the beginning. Guide is not sitting well, just to be coaxial. You can, even though you may not need it for support, I think it'll help with delivering stuff just before you get into this. Now you have the stent hanging in the aorta, and the question is, you know, you want to get it out there before it embolizes. But guide extensions can be very helpful in this situation for sure.
And I would add, or alternatively, a buddy wire. You can take your wiggle wire right along your working wire. Not only does it give you more support, it lets you advance devices over a much more flexible wire that can often allow them to make curves you can't make with that really stiff-bodied wire.
Yeah, no, those are great points, and I think I underestimated the, you know, the tortuosity. The lesion itself didn't look very calcified or anything, but, you know, just underestimated the tortuosity. I think if maybe I, you know, really prep much better in my head, probably I could have put a second wire, or as you mentioned, Catherine, you mentioned a wiggle wire. I mean, you know, it's so helpful. I've used that in so many procedures, and it really makes life easy. And I learned that from Dr. Ayer. Now, he was my program director at the, my cath lab director at the time when I trained. But it's a great wire.
Yeah.
Any other?
Just one question. Generally, how do you guys prep the stents? Do you prep them at all? When I was trained, we used to prep them. Now, you know, reps have told me that, you know, we shouldn't be prepping them at all.
Exactly.
And that's what we do. We don't prep them anymore.
We're told not to prep.
Right.
But I think now that we're in this situation, I think, you know, the question I'm asking myself is, am I crushing the stent to the wall? Am I leaving it there, or am I going to get it out somehow? I think, you know, given the anatomic situation, I think there is some reason for optimism about snaring this and pulling it out. But we'll see how that went. But I think that's kind of now the algorithm that my mind is
maybe I
traveling
missed
down.
it, but is this whole stent in the RCA, or is it
Well, it's hard to
protruding?
tell because I can't inject,
so
and I wouldn't know.
okay, there was no
but you can
injection.
see that the guide was sitting right there. So I think it's probably in the ostium still, and with overhang outside into the aorta.
It looks really radiopaque for, you know.
It's a synergy stent.
That's right.
Well, because it's not expanded either, so.
Yeah, it is synergy. Yeah.
If it was the Biotronic, you'd probably not be able to see it well.
All right. Well, I love synergy stents. I'm just saying that was the. All right. Can I move forward? Yeah. Okay. So, like I said, we tried multiple guides. I even, you know, I sending a snare in. I mean, I couldn't even get. I tried airmailing a wire into it. We tried, you know, getting a snare up to the ostium and trying to get it. Just couldn't get it. I mean, I couldn't get anything. My partner came to help. Didn't work. So next, what happens is, you know, I tried to do an injection, and the next thing I see is that you can tell it's not in the ostium. So now it's in the aortic, it's in one of the cusps, I think. And so the mistake, I think we were thinking that it's in the ostium. Maybe it was not exactly in the ostium. Maybe it was all the time in the cusp. I can't tell. But from this view, we kind of figured that it's probably in the cusp, and, you know, tried getting a snare in and tried to pull it out. Still couldn't get it. Didn't work. And so after that, now this is a, sorry. So just it didn't work. And then now you can see that it's now no longer in the cusp, it's now probably in the left system. So it just goes off into the left system, and now it's, here it is in the proximal left circumflex. So it's very interesting, went from the ostial RCA into the cusp, jumps into the left cusp, and then it's in the left circumflex. So now, I'm happy that it's not outside floating and we haven't lost it. It's in a big vessel. Now what do you do? Would
Maybe
you
it's
stand it
just-
right here, or what would you do?
Circle looks easier to manage than the right.
Yeah.
And it's good it embolized into something we know how to manage rather than the brain, because I was worried. I mean, it looked like it wasn't in the RCA when I was asking that question, because the way it was moving looked like it was a little bit more, maybe just the tip of it was hanging on a calcium, but then most of it was outside. It's interesting that it went sideways, not upwards towards the brain, and that's good because this is kind of something in our territory which we can manage. So your options here would be to try to wire through it, which is going to be very difficult. Just crush it with another stent, which would be the easiest thing. It's in the proximal portion, big circ, pretty healthy. Hopefully there won't be a lot of restenosis and stuff. You can try to snare it. You need probably a bigger guide. There's always a risk of causing left main issues there, but it's kind of sitting in a nice place. You want to do something before it starts going to other places.
Yeah, those were exactly our thoughts. And as you said, I think we were wasting our time thinking that it was in the RCA, but actually it was not exactly in the ostium of the RCA. And so now, after this injection, you'll be surprised to see it goes further down. It migrates all the way down into the mid-circumflex. And there's some disease in that area, and so we didn't, initially I was thinking maybe if it's in the proximal circ, we can snare it out, or, put another 2 wires and then kind of, bring it back, or put a balloon and bring it back. But after it jumped into this position, we decided, okay, that's fine. We'll just crush it. It's a big vessel. On IVIS, the size was 3.5 to 3.8 distally, and there was some disease, so we just crushed it with another Synergy stent and then post-dilated it with a 3.5 by 20. You can see that portion of the vessel is diseased. And then this is the final IVIS. I can't drag it, but it was a good, you can see all the 3 layers, and there was good area. Let me just see if it shows. It's a bit slow.
So what happened with the RCA next?
Yeah, we
still
brought her
have that
back
problem.
later, and yeah, we fixed it. Again, same thing. We did a better job with the guide and then using a more stiffer wire and everything else. So you can see that the 3 layers of stent. All right, so do we have time for a couple of didactic slides?
Yeah, a few minutes. So,
You have 3 minutes or so.
Okay, so stent loss can be partial or total. It can be in the coronary or the aorta or peripheral system. You can lose the stent completely, or you can have the guide wire in place. So depending on these, the management steps will follow. So if you have a partial stent loss, you already know that the balloon is there, so you can dilate it to maybe 3 atmospheres and then pull the whole thing back. Now if that doesn't work, maybe try a new balloon, put it distally, and then again same thing, inflate it to maybe 3 atmospheres and bring it back, or wire next to the stent, put a balloon and then bring it back. Now, if that doesn't work, snares or using multiple wires and trying to pull it back is another way. And then if there is a stent vessel sizing mismatch, then you can crush it like we just did. And then the other thing is you can use a proximal balloon and send it distally and then deploy it there. If the stent vessel mismatch are well matched, then you can just deploy it where it is. Now, if there's a total stent loss, with the guide wire in situ, you do all of those, or you can actually just try and remove it with a snare, or again use that wire technique, or you can, if you have to deploy it, then you just follow the other techniques. Now, what if you have the total stent and guide wire loss like we did? Then obviously you would want to get it with the help of some sort of a snare, or crush it into the vessel like we just did. Usually they advise not to do this if it's in the left main. You try it out, bring it out with the snare. You don't want so many layers within the left main. Now, if it's in the periphery, if it's in going to the head and neck vessels, then obviously you want to call a neuroradiologist. If it is above the femoral artery, then you can use a snare, and pretty obvious, if you can see it on fluoro, it's much easier. You can just bring it out. If it's below the femoral, then maybe you just do conservative management. And if you can't see it on fluoro, kind of, consider a DSA or, even a CT scan, and then same thing, if it's above in the head and neck vessels, then you call a neuroradiologist or a very professional, well-trained peripheral interventional cardiologist. So some things to remember: adequate anticoagulation is very, very, very important. Maintaining your guide wire position as long as you can, monitoring balloon markers, and then make sure you don't put too much pressure because you may have the risk of embolization. And then once you get the stent out, make sure it's complete, and then if it's in the left main, probably retrieve favored over crush. And so common causes of stent loss: severe calcium tortuosity, poor vessel prep, etc. And adequate vessel prep is so important to prevent it. And when it occurs, then you can use an algorithmic way to actually retrieve it. And it's really important to be prepared if you do have an event like that. So thank you so much.
Thank you.
And if you have any questions, I have the microphone here, so feel free to raise your hand, they will come to you.
Anybody has a question? We have kind of, if not, so this is very good. What if we want to talk about prevention? Like, what would you do to prevent this from happening so you don't have to do all this?
Yeah, and Poonam, kudos to you for taking care of this patient and getting to a good end here. But I think the key thing is the right coronary artery has to be respected, especially when you have those tortuosity. Getting the good guide that sits properly and aligned is key. And I think Katie mentioned this as well, but also having supportive wires to help with that tortuosity. So even if you don't have a wiggle wire, sometimes double wiring can help as well, have a second wire in there. But good guide positioning, good guide support, and then supportive wire.
Yeah, I totally agree, and I would like to add good preparation of the lesion. Sometimes lesions heavily calcified, we tend not to treat adequately, then we have trouble delivering. So I believe here was a combination of the lesion and also the tortuosity there.
I think the other last point is making sure the stent, when you take it out, if you're not going to deploy it, is still on the balloon. I mean, that's an important thing to look at.
Perfect. All right. Well, we'll keep going. Dr. Tsai is next. He's going to talk to us about balloon fracture and entrapment. Thank you.
Just one other comment.
Yes.
This catheter doesn't go, don't try to advance a stent. That's like a pearl that everybody needs to realize that, because if you can't get a Boston or a volcano iris to cross the lesion, that's telling you that you haven't prepped the lesion adequately.
All right, thank you for the opportunity to present today.
Dr. Tsai, I just want to remind all the speakers, if you don't mind, just face the cameras because this is being recorded. Don't worry about us. Keep your back towards us. We'll be okay with it.
Got it. So you've caught me in a very introspective mood here. I'm 16 years out. I've had a couple long cases this week. And my kids are home from college, so my house is very busy. And they ask me questions like, Dad, how was your day today? And, I can't help but share this slide that I give them the analogy of what we do in interventional cardiology as being a pilot. And I tell them that every case that we do is like the plane takes off with your cath lab staff, and then you got to land the plane. And you don't know necessarily how that flight is going to go. And thankfully, usually it goes pretty well. 40-minute flight to Grand Junction, you drop the patient off, everything does well. But this is one of my favorite stories about Captain Sully. Think about him as an interventional cardiologist in 2009, when they took off from LaGuardia for a routine cardiac catheterization, let's say with their team, and then right into the flight, they have the bird strike, right? The Canadian geese take out both engines. And he and his co-pilot have to decide, how the heck are we going to land this plane? And so amazingly, as you all know, 4 minutes later, he lands that plane in the Hudson and saves all 155 people on board. And other pilots will say that's a 1 in 1,000. 999 other pilots would not have saved that plane. They would have made a bad decision. They would have had fatalities. And when they interviewed him, he essentially said, for 42 years, I've been making small, regular deposits in this bank of experience, education, and training. On January 15th, the balance was sufficient so that I could make a very large withdrawal, and that was that day. And as interventional cardiologists, this is why we are here, to learn from each other and to learn tips and tricks so that we can land the plane no matter what their circumstance. And I can't thank Manos enough for his contributions to this area his step-by-step PCI manual. I don't know if you guys have gone to YouTube, whether it's wire externalization, stent loss, antegrade wire entry. He has amazing talks about the step-by-step method to get out of trouble. So thank you, Manos, for all that you do and for running conferences like this so we can become better. And I tell the kids, it is our skill set and our experience that gets us out of trouble, and these are patients' lives. So we're all aspiring to be the best interventionalists we can be or the best cath lab team. So I'm going to move on here. Sorry for that emotional segue, but this is how I really feel as we're trying to do this like Captain Sully. And so this is a regular day in the cath lab. I'm taking off with my team, 70-year-old man, ischemic cardiomyopathy, EF 30%, previous stents in the RCA and LAD, with previous just mild disease in the OM on the last cath. And he has classic angina on medicines. So you can see his RCA stents look widely patent. You can see that his LAD stent is patent. And then you'll notice this very innocent appearing obtuse marginal branch that has a focal stenosis. And so before anyone says, don't just hit that, it's, don't do an oculostenotic. We did an EBU guide. We did an IFR, it was abnormal. Patient has symptoms, so we gave crushed prostaglandin bivalve, and we got started. So I'm flying this plane with the team, and everything's going fine, and no excitement in flight here, 2515 balloon. Any considerations from the panel in terms of this very straightforward case weekday 40-minute flight we're about to take?
There's a little bit of calcium there. You can see it before the dye hits that area. I'm sure some people would want to IVUS that, but to be very honest, probably most operators would not. But imaging is never a bad idea.
So yeah, I think we get a lot of feedback from the wire, from the appearance of the lesion, of just how recalcitrant that lesion might be. And I was not fazed by that. It looked pretty straightforward to me. Take a 2515 balloon and I dilate it. And we all know that if there's a waste, then perhaps we should do some lesion modification that's more aggressive, let's say, than a balloon. But gosh, I don't know, that looks pretty well dilated. We always IVUS. You can see the IVUS images where there is calcification. Not quite 360 degrees. Gosh, my balloon yielded. Didn't think this was going to be an exciting flight here. Based on that IVUS, I don't know, does that change any of the recommendation on the panel in terms of if you would now say, I'm going to roll to that?
How long an area of calcification was it on the IVUS?
I'd probably say like 10 to 15 millimeters, so just that focal area.
Because I mean, if it's 10 to 15, to that degree of circumferential calcification, I would think you'd want to do some sort of modification besides balloon. I think if you were able to get your balloon through, probably, in my opinion, I would use an IVL because it looks like you're able to expand it, and it's just relatively
Yeah, I mean,
focal.
the balloon expanded very nicely. I don't know what the IVL is going to offer, at least.
Well,
At least,
I'm thinking
I
for
mean,
stent expansion.
unless in this view it's expanded, and if you take an orthogonal view, it looks not very well expanded. But in this view, it looks like really good.
Yeah, and I think, that's what my impression was, gosh, the wire wired very easily. Sometimes you get feedback from the wiring. If it's kicking your guide out, you have a very recalcitrant area. The wire wired easy, the balloon looked like inflated. I thought, gosh, this looked okay. And this IVUS, I look at the IVUS, but it didn't make me think I needed to now put a rota in there and start burring this thing. And again, my take-home point number one, Manos wanted take-home points, is failure of preparation is preparation for failure for sure. So if you have an opportunity to prepare for a case, you should do so. But also, if you've underprepared the lesion, like that first amazing case where who would have thunk that stent would go down into the left coronary system, that's crazy. But I didn't think necessarily that this lesion wasn't well enough prepared. But of course, so I continue with the case. I take a 2.5/24 synergy, goes down very easily. You can see here that, let me go back one. So that's the pre-stent, post-balloon, and here's the post-stent. So what are you seeing there? There's an eccentric narrowing or a waist in that stent. And so what do we usually do when we see that? We hit that. We hit it with an NC balloon. So there's a clear waist, so I was just going to hit that. And you can see here this REE stands for Rich Emotional Experience. So everything was fine, and I'm using the different NC balloons. You can see that's I think a 2.5 or 2.5 by 6 at high
Tsai,
pressure.
let me interrupt you if you don't mind.
Yeah.
Do you think that very focal area was missed on the pre-dilatation balloon? The pre-dilatation balloon was distal to it, maybe, or at the kind of tapering of the balloon, because you would think you would have seen that.
Yeah, I don't think so, though. We looked at that pretty closely, and we covered the area for sure. I agree, though. We didn't see it, but we're obviously seeing it with the stent. And
you
so,
did it in two views, like.
yeah, I mean, I would like to think I went orthogonal views there, but I'm not exactly positive. But obviously, I see it now. And so you have these short balloons that have a waist. And then, you know, we take an imperial balloon. To me, an imperial balloon has a little more, you could put a little more pressure in there, up to 30 atmospheres. And we should all know that once you exceed the tolerance of most of our devices, you know, bad things can happen. But you know you can get away sometimes. I'm going to go ahead and, I know we have 7 minutes of discussion, so I'm just going to fold it in all together. You can see, though, I use these different, angioscope will not deliver. I don't think a shockwave would have delivered either there after the fact. And then at 30 atmospheres, the balloon burst. And so now we have this situation. So after the balloon ruptured, I tried to pull it out. Obviously, the guide went deep, and you can see what the picture looks like. And so that balloon is stuck inside the stent. So panel, help me out here. So let me ask you this. Who would do this? Right? Who would just pull harder? This is for the, I think, the Miami rowing team. This is not for interventional cardiology. Okay, so my take-home point number 2 is, in general, the answer is almost never to just push or pull harder. Interventional cardiology is a finesse sport. It is not a muscle sport. And so this is, my kids saw this and said, Dad, you're pretty, you know, contemporary. Like, that's pretty good. And so that's a more recent song by Bruno
So Tom,
Mars.
the issue with pulling harder is the balloon shaft will just elongate. It'll keep elongating, and then you'll be left with this ribbon, right, hanging out of the
Sure.
left main,
Yeah.
basically.
So help me out here. What would
It
you
can
guys
also
do?
pull the stent sometimes if it's quite hard.
So some things you can do, probably wire next to it, try to balloon slowly and see if you can dislodge it. I've had one case where unfortunately the balloon itself got sheared off the shaft, and that's a big problem because that's foreign material that's going to stay there. Other things, you can, you know, cut the balloon from the back and advance a guide extension over that shaft and try literally to kind of, you know, go over it. You have a risk of stent deformation there, obviously, but these are some initial thoughts that I can think of. Anybody else has, or the audience, anybody has any idea?
Not yet.
You can cut the hop proximally, put a snare on and pull like crazy.
Okay. So snaring, you brought up guide extension catheter, trying to wire next to it. And so thankfully, you know, again, I'm not joking, Manos. I really do look at your algorithms and look at this step by step and watch your videos. Manos and I worked at the VA, different VAs, 16 years ago. It's been amazing what you've put out there for us to learn from. So what's going on here? I think we all understand this phenomenon that this balloon that's deflated, and these stalactites and stalagmites or the stent struts themselves can really inhibit your ability to pull that balloon out. Sometimes the balloon won't even deflate because you've damaged the hypotube. And so that's what's going on here, is you basically have a situation where that balloon is folded over itself and stuck in the artery. Now, call a spade to me. It's just like the first case. Obviously, in retrospect, we would have loved to have prepared this lesion better. Of course, I would have wished I would have rotoed that, you know, just not be in the place that I am, but I am. So clearly, doing that is important, so always trying to prevent the complication is preferable. But now we are where we are. I think we all don't want that. We all know we can send this patient to surgery, and they can put the patient on pump, create an arteriotomy, cut that plaque out of there, and pull the balloon out from the inside. But that's a sternotomy and open heart surgery. So hopefully, because of conferences like this, we can figure out different ways. And so our options are, again, balloon-assisted guide anchoring. You can actually blow up a balloon in the guide next to the balloon to give yourself a little more support. Guide liner assist, as was mentioned, cutting the back end off the balloon and advancing a guide liner or a guidezilla of the appropriate diameter to change the pressure point, right? Where you're pulling from gets changed tremendously. This Guidewire microcatheter next to the stent, it's just hard because you saw that picture. There's just not a lot of space. And if you want to use a very stiff wire, you have the risks associated with that. You can also do other catheters, filter easy bed. You can put a 5 French catheter over the wire and try and do that as well. And then you can snare, as you saw before. And then there's a mini star technique. So I do CTOs, and I'm very familiar with trying to go around. You can try and go around this lesion and use different mechanical methods to try and get that balloon out of there. So, you know, this was, the patient was having some symptoms of ischemia, some discomfort, but I assured people in the lab as well that, you know, you have patients coming in who are ischemic 4 or 5 hours into it without electrical instability or hemodynamic instability. You don't have to panic here. Chest discomfort, you use some medications, get the patient relaxed, but there's no reason to hurry necessarily. You can see my parallel something. I tried it. It laughed at me. There's no way I'm getting a wire next to that entrapped balloon. And then this optimizing the physics here with the guide extension catheter. I cut the balloon off at the end. I put a 6 French guide liner in there. Who knows who this person is? Raise your hand if you know who that is. Who is it? Piglet, okay, thank you. This is the example when you're out gardening and you're trying to pull your weeds, you don't pull the weeds from the middle or the top because it's going to snap. In the same way what the guide liner assist does, it allows you to get that just like putting your hand at the base of the stent where the balloon is and changing the force and pulling from there. So the guide liner assist gives you tremendous physical advantage over trying to pull without the guide liner assist there, just like Piglet's doing there. Now, there was not a lot of flow. He was having some symptoms during this. But again, he was mechanically and electrically stable, and so we weren't panicked. This is Dr. Velagaputi's algorithm that basically goes through this balloon entrapment, balloon failure to deflate, or balloon shaft fracture. I'll say that, you know, before doing these mini star techniques or calling the surgeon, you should try these different things, especially the guide extension catheter. Because from the literature, if you look about this, that usually will work, changing the physics of where you're pulling from. And so, of course, we called my IR colleagues, CT surgery, had them on standby, because the answer to this was I was going to pull harder. I didn't have another solution here. But if I'm going to pull harder, I want to make sure I have everyone back up there. If I needed to go to the OR, I put a ping pong guide up there, Andrew, so that if I had some mechanical disruption, that I could fix percutaneously, I was ready to do so. You can see that we got access on the other side. And then this is our push, pull, and pray. Triple P, hardest I've ever pulled. But I did it pushing the guide liner down as I was pulling, and it came out. And you can see here the next picture shows that everything looks okay. There's no dissection there. There's good flow. The patient was asymptomatic. So I think the guide liner assist should be the early default strategy to liberate entrapped devices in general. That should be something that you're very familiar with and comfortable doing. After 10 minutes, obviously we waited, and 10 minutes later it looked fine. And then 18 months later he did have some unstable angina. Came back to the cath lab, we took the pictures, it looked the same, and it was IFR negative. Here it says FFR negative. So really didn't necessarily need to post-dilate that, but of course we never want to leave a waste behind. So to finish up here, failure preparation is preparation for failure. The answer is almost never just push or pull harder. Remember the tolerance of our devices and the trouble you'll get into if you try and exceed that. It's about finesse. And number 3, I think the guide liner assist should be the early default strategy to liberate entrapped devices. And my final thought is just, you know, the goal here is to land that plane safely, and all of these things that we're learning in conferences like these are trying to get us better at doing this as a team. So thank you for your attention.
Thank you. Our next speaker is Dr. Azzalini for Guidewire fracture and entrapment.
Thank you. So, these are my disclosure. This is just another routine case, a second CTO of the day. It's a RCA CTO, 81-year-old man with ischemic cardiomyopathy, and he had just undergone PCI of the left-sided system just 4 weeks earlier, and those will come relevant during the case. And he comes for staged RCA CTO PCI. There is a lot of calcium. We go antegrade. We have even to shockwave and drill the proximal part to advance our gear. But then in the distal part of the RCA, we cannot advance. It's just impenetrable. So there are collaterals. What do? We try to go retrograde. And so immediately after advancing the microcatheter with the workhorse wire into the LAD, we noticed that there is a resistance upon moving the guide wire, the run through, and there is like a little dot there. And it means that the wire basically is stuck and is damaged. Importantly, due to logistical misunderstanding, the patient had been scheduled just 4 weeks, literally 28 days after the initial intervention. So the stent was rather fresh. So we pull, of course, gently, and the wire is coming out, apparently, but it's not. Because you see the dot there? It's the damaged wire, and the wire from the other side is coming out. So this means that the wire is unraveling. So, of course, we should not keep pulling. So the question is, what do you do at this point?
So just a quick question, just like we saw at Dr. Tsai, did we try to keep that catheter all the way down to the tip and pull with that? Because
yes.
Okay, yeah.
I already had the microcatheter because I was about to go retrograde, so that's the
I can tell you
first
what not to do is not to keep pulling, because that wire is going to keep elongating
Yeah.
and getting worse, and then it'll be harder to see.
Yeah.
So, I mean, obviously, let's pass it on. What would you do next?
So a couple of things you could try to do is, you already know that you can try and get a balloon down there and see if that can inflate the balloon and see if that can help dislodge it a little bit from the wall where it's entrapped, and then that can help you get it out a bit. So that's one thing I would try.
Or
We
maybe
have
a
a-
microcatheter.
I had the microcatheter there and tried. The problem is that the wire is unraveling, so I would be advancing a balloon over a 002 wire.
Yeah.
So zero support.
So it looks like it was pretty proximal.
Yeah.
And so I wonder if putting just like essentially using a trapper balloon inside of your guide to get the guide in as deep as you can, and then kind of pulling with the counter pressure on the unraveled part, so you're not unraveling more. But I've never done that. I don't know if you'd get enough force against the wall of the guide to pin it. But maybe with a 2.5, you're probably 6 or 7 French, so a 2.5 or 3.0 balloon.
And I would have a similar thought with a smaller guideliner, assuming your
Yeah,
wire
it's a
is
similar
still
strategy.
in one piece, which is always a little bit uncertain when it starts unraveling.
So Lorenzo, what you don't want is
Yeah.
the wire having traversed through the left main, or getting portions of the wire in the aorta.
Exactly.
What you want at this point is getting the wire broken within where the LAD lesion is, and then you can rewire and put another layer of stent.
Yeah.
And that's sort of the ideal scenario. So whatever you need to do at this point with a microcatheter, and if you need to balloon, as Kate said, to trap the wire where it is and then pull such that it snaps within the LAD with no segment within the aorta and within the left main.
Fair.
It's hard to say if you can trap the unraveled wire, because it's going to be, as you said, so thin. I wonder if the balloon will keep it in place, because you can definitely keep a whole wire in place, but that unraveled, do you think the balloon will trap it in the guide? That's the question.
Rewiring,
Yeah.
and then you could then take a balloon to now deep seat the guide.
Yeah.
The guide extension catheter next to where your entrapped wire is, and then with that balloon inflated with the guide extension catheter, pull it back together.
Yeah, the goal is very important. The overarching goal is not to have any filament in the aorta because it can be a source of systemic embolism, namely stroke, first and foremost. It's unpredictable how the wire can snap, but for the sake of brevity here, I'm going to show you condensedly what I did. So we had tried to advance a guide liner over the filament to then advance a microcatheter to just concentrate all the force and do a localized pull, but pushing the guide liner just pushed this filament. You can see now there is this weird mass on the left side of the screen outside in the aorta. We tried even to snare with a coronary snare a 4 millimeter gooseneck. And also, if you can see, the stent is now deformed. It was not, because we have IVUS demonstration of how it looked like just a month ago, because probably the wire hooked the stent, and by pulling it back, dragged the struts inside the coronaries. And this is the final result just 28 days earlier. It's a 3.5 megatron positive with 3.5 NC, and that is exactly the spot where this problem happened. Angiographically and IVUS-wise, it looks good, but this is what happened. So at this point, the wire with all these maneuvers broke, and so we had, like, the outer end was out, and we have this filament floating in the aorta. But if you can see here on the bottom part of the screen, the dot is still in the coronary, so it means that either it fractured in 2 points, or more likely, that stuff that we see in the aorta floating is connected to the coronary. So now it gets more complex and more fun. So what do we do now?
I mean, to me, at that point, the only thing you can do is try to snare it as close as possible to the left main, and try to get whatever's in the aorta all into a bigger catheter. Otherwise, it'll have I mean, if you keep things floating in the aorta, they're going to have to go to surgery, unfortunately. So snaring, I would say snaring.
Any other opinion, or should I just go to the solution?
Is there a way you can somehow image to understand what it is? I mean, I'm trying to think TEE or something to understand if it's connected or not connected.
Yeah, I mean, the patient was awake. It was not a GA case, so we would have had to intubate the patient. But I think it was connected to the coronary because the dot stayed there. But basically, what we ended up doing is to use a large tulip-like snare, like this 1830N snare that we use in retrograde CTO PCI, and you can see that we're able to capture that weird mass of filaments. So at this point, we gotta be very careful, because if we keep pulling, we might break the filament elsewhere, not in the coronary. It might break in between the coronary and where we caught it. So we advanced bare balloon, 3.0 balloon, to the, as far as possible into the guide, basically the tip, to trap it there. And then at that point, we basically pulled everything out because of what I just explained, that otherwise we didn't want to leave any other fragment in the aorta. And so this is what we did, and we pull everything out, and you can see that in this inset that the dot that was before in the coronary is now in the guide, so it means that we have 100% of the wire with us. And this is how it looks. It's almost transparent. This is where the blood thing is, and also it goes a bit up there. But of course now we have a problem that the stent is all mangled up, is damaged, and when we try to rewire it, immediately, even with microcatheters and regular wire, it goes outside the stent strut because it's grossly malapposed now. So what we do is we leave that wire there, and with a dual lumen catheter and a CTO wire that has a bit more push through these all these damaged stent struts, we are able to wire distally in the LAD, dilate with great difficulty. We can advance a 125 balloon, then a 2.5 balloon, and this, after 2.5 balloon, this is how the stent looked. So it was much worse than that probably before being able to IVUS. And the vessel is, at that point, is like 4.2, so we post-dilate the stent with a 4 millimeter NC. The stent reacquires its original shape and geometry, and it's perfectly re-expanded. we brought the patient back and we fixed the RCA just 6 weeks later. So this is Manos's algorithm on Guidewire entrapment. Most important thing is do not pull hard. If you can free the wire with advancing a balloon and inflating it, or just pulling with over a microcatheter. We can also wire with a second wire beside the first entrap wire, and then inflate a balloon to free it. If the guide wire fractures, we can, depends if it unravels or not. If we can, and it did not unravel, the fragment is always completely contained in the coronary, we can just stent across it. Another technique could be, if it's if the intention is to pull it out, is to use multiple wires and twirl the wires around the fragment, or again, the coronary snare. And then last resort is emergency surgery. So in a different form, I condense this algorithm in this principle. So we have to, if this wire gets entrapped, we have to pull it gently. If it doesn't get free, we should immediately stop pulling it. Of course, for fellows, it might be difficult to gauge how much is gentle or what's the limit. But with experience, hopefully we can get there. We should advance a microcatheter over the wire and exert localized traction. This can be supplemented by a guide extension, or we use the second wire and balloon to free it. Regarding if we can or cannot abandon the wire in the coronary, we can only abandon it if it did not unravel in the aorta. If it did, there is a risk of systemic embolism. IVUS can help elucidating if the wire unraveled or not, because basically you don't see it on angio, you put an IVUS probe. If you don't see it on a careful IVUS interpretation, probably there's no wire, and the fragments are usually seen on IVUS. If you decide to leave it in the coronary, unless it's very distant in a small branch, you can just stent jail it. We demonstrated the intracoronary and then the intra-aortic snaring. I've never done it personally, but you can also use rotational atherectomy to create a clear fracture point of the wire in the coronary. Of course, there is also the risk of getting the wire entangled with the rota. And the last resort is surgical removal.
Thank you so
very
much.
much.
Thank you. All right, we'll move on. There's unfortunately we're over time for discussion, but very good case. Thank you. Next is Dr. Pershad. We're going to talk to us about microcatheter fracture and entrapment.
Oh, wow, this is a session, isn't it? So anyway, microcatheter fracture and entrapment. After all the Guidewire stories and horror stories, here's my case. So this was a paper that Mike Migali and one of our fellows with Manos and we had collaborated on related to what the failure modes of microcatheters are in the MOD database. And here's just a brief overview. The most common problem is the tip of the microcatheter fracturing. And usually the mechanism for that is over-torquing, or either, as we've heard about 3 times already, forceful pulling is not a good idea. And then on the pie chart, you see a bunch of catheters out there, and you can see that the Caravel, which is not designed to be torqued, is the most common microcatheter that tends to fracture. It usually does poorly in calcific CTOs. And then in addition to that, I think just the Corsair, just by virtue of it being the most commonly used microcatheter, comes second at 19%, and then followed by a bunch of the others that sort of complete the list. The consequences of microcatheter fracturing, unfortunately, are not trivial. Oftentimes leads to going to surgery, 7% of the time. And then oftentimes the procedure needs to be aborted or have to deal with situations that arise as a result of that. So having said that, let's discuss this case. This is a 68-year-old gentleman with an ischemic cardiomyopathy with stents to the LAD that were okay and a CTO of the mid-right. EF was low, and so he was referred for CTO PCI of the right coronary. This is just the plan. Primary attempt was to go retrograde because of the prior antegrade attempt and poor quality of the distal vessel. So again, choice of catheter is important. So Caravel was used and an XTR was used to wire the septal. I don't think that that's the choice that I would do now, but this was what was done. And then I think just a quick question to the audience and whoever's strategy would be, I guess, in situations like this. My strategy is usually a Turnpike or a Corsair with a Xi'an Black. Is that sort of the general theme?
I'm a Turnpike LP and a Xi'an Black.
There you go. So yeah, so clearly not caravels unless it's an epicardial or if it's a highly tortuous collateral. So anyway, so here's what we did, and just after that, the caravel would not advance, and we lost everything, and so we had to start all over. And so we this time opted for, I think, another wrong choice. This time we used a Xi'an Black and a fine cross, and you can see that the black crosses pretty easily. The fine crosses in the PDA, and you can see that with the tip injection in the right panel. So then we get some antegrade work done with a guide extension and a pilot 200 knuckle and a Turnpike LP, and perform reverse cart at this point. And you can see that the microcatheter that's retrograde now cannot be advanced, cannot be pulled back, and is essentially trapped